Hello friends, now we'll be discussing a topic of undescended testes. Before starting, I would like to thank Chandana Shri Ma'am for sharing the wonderful notes with us, which are very helpful for quick revision. You can download the notes from the link below, uh, which is given in the description, and these are very helpful for quick revision. And so without further delay, let's get started. So undescended testes or cryptorchidism. So before starting, we will see the embryology, that is testicular development and testicular descent. So here there will be absence of testes in the scrotum of the male individual. So if this occurs outside the normal line of descent, it is called ectopic testis. So testicular development. So primordial germ cell arise in the yolk sac, that are the primary cells, and migrate along the dorsal mesentery. That is done in the third week of gestation, that is happening in the third week of gestation, and these reach the gonadal ridge in the lower thoracic and upper lumbar region. So there surface epithelial cell sorry surface epithelial cell from the genital ridge, they invade the mesenchyme of the gonadal ridge, and these give rise to primitive sex cord. This happens in the 6th week of gestation. And these primitive sex cord, these are indifferent gonad. When there is Y chromosome, these will result in formation of SRY gene products, and that will give rise to testes. And in the absence of SRY gene products, there will be indifferent gonad. It automatically becomes ovary. So genital ridge that will be forming the gonads. So the urogenital ridge, the medial part is the gonad along with the mesonephric duct, and the lateral part is the paramesonephric duct, which disappears due to MIS, that is Mullerian inhibiting substance, from the Sertoli cell, and the paramesonephric duct disappears, and Leydig cell arise from the coelomic epithelium and perivascular cells near the gonad, that is the mesonephric border. These give rise to testosterone. So the primitive sex cord, these will form the rete testis and will connect with mesonephric tubules, which in turn will connect to the efferent ductules. And the primitive sex cord will undergo canalize to form the seminiferous tubule. Some of the epithelial cells from the primitive sex cord will differentiate into Sertoli cell and will give rise to AMH, that is anti-Mullerian hormone or Mullerian inhibiting substance. So like this, there will be development of testis. Then the testis will descend from the abdomen to the scrotum. So before gonadal differentiation, the testis is near the developing kidney. So in the abdomen, in the retroperitoneum, so there it is loosely held by two ligament, that is cranial ligament, which regresses, and caudal ligament, which develops into gubernaculum in the 7th week. So gubernaculum is a mucofibrous tissue or structure that is attached to the testis and scrotum, and it guides the descent of testis into scrotum. So it takes testis along with it to the scrotum. The distal end of the scrotum is attached to the fascia between the abdominal muscle initially, and then descends to the scrotum along with processus vaginalis. So initially the distal end of the gubernaculum is attached to the abdominal muscle, and later it descends to scrotum along with processus vaginalis. So in the 8th to 28th week, it is the transabdominal phase where the testis descends from the retroperitoneum up to the deep inguinal ring. Due to regression of the cranial ligament, due to androgen, thickening of the gubernaculum, due to insulin-like factor 3 from the Leydig cell. So these all will result in the transabdominal phase where the testis will go from retroperitoneum to deep inguinal ring. Then the inguinoscrotal phase, which is lasting from the 28 to 35 weeks. In this, it is under androgenic control and due to CGRP, that is calcitonin gene related peptide from the genitofemoral nerve, and aided by the transmission of the raised intra-abdominal pressure via the processus vaginalis and shortening and traction of the gubernaculum. So this will cause the shift from the inguinal region to the scrotal region. So 28 to 35. So the timeline, in the second month, there will be testis will be in the lumbar region. In the third month, it will be in the iliac fossa. And in the seventh month, it will be in the deep inguinal ring. In the eighth month, it will be in the superficial. In the seventh month, it will travel in the inguinal canal. In the eighth month, it will be reaching the superficial inguinal ring. And in the ninth month or after birth, it will reach the scrotum. Now we will see the incidence of undescended testis. So in preterm it is 30%, in term babies it is 1%, and at age 1 year it roughly reduces to 1%. So postnatal descent of testis occurs up to 3 months. So after 3 months it is rare. So undescended testis, two-thirds of these cases are palpable in the inguinal region, so they have reached up to the inguinal canal, and rest are impalpable, so they can be in the abdomen or can be atrophic. So what are the associated anomalies in these cases? There could be patent processus vaginalis, which could result in hernia, that is an indirect inguinal hernia. Then there could be epididymal anomalies. Also, there could be hypospadiasis or urinary tract anomaly. There could also be congenital cryptorchidism, where there is extrascrotal testis at birth. Acquired cryptorchid testis documented as scrotal in the previous examination. So these are two types of cryptorchidism. Then the retractile testis, where the scrotal testis that retracts easily out of the scrotum but can be manually replaced in the stable scrotal position and remain there at least temporarily. So here the testis retracts upwards but can be brought down and will remain there at least temporarily. Based on the location, the testis can be in the lumbar region or iliac region, inguinal region, in the superficial inguinal ring, or the scrotum, that is the upper part of scrotum. So it can be in any of these places. What is the etiology? So there could be any hormonal defect due to defect in the hormonal axis, that is HPG axis, and the Sertoli Leydig cell dysfunction, genetic susceptibility, environmental risk factor, that could be due to maternal smoking or organic pollutant. Then there could be syndromic cryptorchidism, that is due to androgen biosynthetic defect, androgen insensitivity, Leydig cell, Leydig cell agenesis, gonadotropin deficiency disorder, persistent Mullerian duct syndrome, Klinefelter syndrome, or prune belly syndrome. Then we'll come to ectopic testis, that is if the normal path of descent is not followed and it is somewhere else, although the testis is otherwise normal. And in case of undescended testis, the testis is sometimes underdeveloped. And the ectopic testis, the incidence is very rare. Now the pathogenesis as per the Lockwood theory. So gubernaculum has 5 tails. So major is in the scrotal one. The other are the pubic, which is attached to the pubic tubercle, perineal, which is attached to the perineum, inguinal, which is in the front of the inguinal canal, and femoral, which is attached to the saphenous opening. Sorry, my computer is dysfunctioning today. So this scrotal tail is the strongest and other tails usually disappear. So if any of the other four accessory tail becomes stronger, then the testis is pulled to that region and becomes ectopic. So it could be any of these regions. That could be superficial inguinal pouch, which is the most common, lateral to the superficial ring between external oblique aponeurosis and Scarpa's fascia. It could be pubopenile in front of the pubis at the root of scrotum, perineal in the superficial perineal pouch in front of anus on one side of midline, or it could be femoral near the fossa ovalis or contralateral scrotum. So the difference between undescended testis and ectopic testis, there is arrest of descent in undescended testis and there is deviation of path in ectopic testis. Undescended testes are generally underdeveloped. Ectopic testes are normally normal testes. In undescended testes, the scrotum is also underdeveloped. In ectopic testes, there is normal scrotum. In both the cases, the scrotum will be normal. Then in undescended testes, there will be short spermatic cord and it will be associated with indirect inguinal hernia. Whereas in case of ectopic testes, there will be long spermatic cord and there will be no associated hernia. Treatment will be same in both the cases, that is orchidopexy. Then we come to clinical feature. It is right side in 50%, 30% left side and 20% bilateral. Then we have a gliding test where we roll the fingers of one hand from inguinal region to scrotum while the other hand at the root of scrotum attempts to grasp the testis. Here we roll finger of one hand from inguinal to scrotum and we try to find the testis, and other hand is at the root of scrotum to grasp the testis. Then we check for testicular position, palpability, mobility and size. Positions in which we check is supine, upright, cross-legged and standing. Associated finding could be hernia, hydrocele, hypospadiasis or underdevelopment of scrotum. Pathology is arrested development of spermatogonia and progressive loss of the testis. Cryptorchidism is associated with primary and secondary effects on the testicular development. So it will be underdeveloped and can result in other issues in future. Retractile versus undescended testis, injection HCG helps in descent of retractile testis, whereas true undescended testis will not descend. Anorchia versus bilateral cryptorchidism, where we check for baseline FSH, LH and testosterone, and in anorchia there will be increased FSH and LH but there will be low testosterone. In if we give HCG in case of these condition, if there is presence of functional testis, it will result in increase in testosterone. Then imaging, we will go for ultrasound, if needed MRI, if there is intra-abdominal consideration of testis, and the best is diagnostic lab, which is the gold standard for confirming the ectopic testis if it is not found in the inguinal region. Then complication of undescended testis. So what we were seeing, the complication of undescended testis, that is torsion, epididymoorchitis, strangulation hernia, trauma, infertility, especially in the bilateral undescended testis, that could be up to 50%. Tumor, that is seminoma. So the complication mnemonic is testis. So there is risk of seminoma. So the risk is maximum in intra-abdominal testis, and most common malignancy in undescended testis is seminoma. Then surgical management. Surgery should be considered once there is failure of spontaneous descent after 3 months. Then surgical correction of cryptorchidism, undescended testis, is indicated to optimize the testicular function first, then reduce or facilitate the diagnosis of testicular malignancy, provide cosmetic benefit, and prevent complications such as hernia or torsion. Ideal timing is the 6 to 12 months, that is corrected gestational age. Then rational is spontaneous descent is unlikely beyond 6 months. So testicular growth is restored after early orchidopexy, that is at 9 months versus 3 years. So orchidopexy for abdominal testis is easier in young infants. So these are to be considered. Hormonal therapy to stimulate testicular descent is not currently recommended. So surgery will go for orchidopexy, and orchidectomy is a treatment option for pubertal and post-pubertal boys because testis is intra-abdominal and difficult to mobilize. And there is poor spermatogenesis and hypertrophy. Hypertrophy is present when the testis is intra-abdominal in the pubertal and post-pubertal stage. Also, there is risk of carcinoma in situ and torsion exists. So approach for this will be, if the testis is palpable in the inguinal region, then we go for open orchidopexy. If it is impalpable testis, we go for laparoscopic approach. So orchidopexy for palpable testis through the inguinal standard approach. Here we testis position is determined and recorded. Spermatic cord is isolated and testis is dissected distal to its gubernacular attachment. Then gubernaculum is transected distal to the sac. Then we go for cord lengthening, that is processus vaginalis is dissected from the cord completely. Incision of the internal spermatic and the transversalis fascia at the deep ring. Release of other fascial bands. Division of the retroperitoneal attachment. Then we may take help of parentis manure, which is the posterior wall of the inguinal canal medial to the inferior epigastric vessel. That part is opened and testis is pulled out through the space medial to the epigastric vessel. So this will shorten the course of testicular vessels and vas deferens, and the testis can be positioned in the appropriate place, scrotum, with less tension. Also, the inferior epigastric can be ligated and divided if required. This adds 1 centimeter to the distance to the testis. Then if testis cannot be pulled down to the scrotum despite all the above measures, then we can go for stage orchidopexy. In this, we have 2 stages, where in stage 1, we will mobilize and fix the testis at the lowest, most distal site possible. And in the second procedure, after 6 months, we will bring the testis down to the scrotum. In Fowler-Stephens procedure, the testicular artery is divided on the assumption that testis will retain adequate blood supply from artery to the vas and cremasteric vessel. Also, this can be done with high ligation of the testicular vessel in 1 stage or 2 stage. But here prior recognition of need of division of testicular artery is needed, so that dissection that compromise artery to the vas or cremasteric can be avoided. In 2 stage, which is a laparoscopic technique, here stage 1, the testicular artery is ligated and allowed to develop collaterals, and subsequently orchidopexy at 6 to 12 months is done. Then we can also go for microvascular anastomosis of the testicular vessel to inferior epigastric vessel. In case of impalpable testis, the laparoscopic orchidopexy, we have various conditions. If there is blind ending vessel and vas, that is absent testis, we don't go for any further intervention. If there is atrophic intra-abdominal testis, we go for orchidectomy. If the testis is amenable to adequate mobilization, we go for orchidopexy. If testis is not amenable to adequate mobilization, we go for two-stage procedure, that is Fowler-Stephens. And if we do not find testis abdominally but find it in the inguinal region, we go for an inguinal exploration. Some techniques like the cough is the low ligation of the testicular vessel, and Sehata technique where there is fixing of the intra-abdominal testis close to the opposite deep inguinal ring and later bring it down to the scrotum in a second procedure. Then we have techniques of orchidopexy. So there is external anchorage where passing the stitch through the tunica albuginea and anchoring it to the thigh, tie over gauze and keep it for 3 weeks. Then we have Ketli-Trope, that is testis is placed in the subcutaneous pouch of thigh and in second stage it is placed in the scrotum. Then Omberdane technique where the placing the undescended testis in the opposite hemiscrotum by incision in the median raphe. And Dennis Brown where purse string catgut suture is used at the neck of scrotum. And lastly, we place it in the dartos pouch. So this was all about undescended testis. Hope it has been understood and will be helpful for quick revision. And keep studying, keep growing, never give up because great things take time. Please like, share and subscribe my channel. And see you in next video soon. Thank you.